Welcome, everyone. I'm Itamar Shapira, Vice President of the Psychedelic Studies Forum. We have Dan Grossman also hosting this, the president. And we are really pleased to have Dr. Marseille here. We have been working on this for quite a while, so we're excited, and I'll give an introduction, just his bio. Dr. Marseille is a leading expert on the economics of the emergent psychedelic-assisted therapies. He's the founding director of the UC Berkeley and UC San Francisco Global Initiative for Psychedelic Science Economics, which is a network of health economists and health services researchers who are dedicated to realizing the potential of psychedelic therapies for high-priority mental health conditions. Through applying policy-relevant economic analyses, this group, also known as GIPSY, seeks to enhance the efficacy of service delivery and increase access to these promising therapies. He's consulted with, famously, MAPS, the Multidisciplinary Association for Psychedelic Studies, for modeling the economics of MDMA-assisted psychotherapy in treating severe PTSD. And with his current projects, he's also working with USONA on analyzing cost-effectiveness of psilocybin therapy for major depression, and with Johns Hopkins in assessing the cost-effectiveness of psilocybin for tobacco cessation. He's also doing systematic reviews of literature on the health effects of access to non-classical psychedelics in naturalistic settings. He has 35 years of senior public health management and research experience, and has published widely on economics of global health disease and conditions, also with a focus on HIV and AIDS. He's the co-course director for the cost-effectiveness analysis in medicine and public health at UCSF. And beyond all of his important work, he has interest in the ethical foundations of cost-effectiveness analysis and identifying sound criteria for judging cost-effectiveness. I think this will be very exciting and very educational. I'm excited to learn what he's going to teach us. So without further ado, Elliot, you're welcome to share your screen with your presentation and teach us.
All right. Thank you, Itamar, and thank you also, Dan, for giving me this opportunity. It's great to be here, and I'm looking forward to sharing some ideas with you and having a conversation. So I want to provide sort of an overview of the agenda for the economic evaluation of psychedelic therapies. And I can get my, I want to cover the following issues. First, I want to address the question, why economic analyses? What are they good for in the context of the emerging psychedelic therapies? I want to provide an example, which is the work that we did on the cost effectiveness of MDMA to treat PTSD. Then I want to discuss more broadly other relevant kinds of economic analyses besides cost effectiveness analysis, and provide another example looking at the effect of a range of possible prices for MDMA itself in the context of MDMA-assisted therapy for PTSD on payers' perspective. Like, how likely are they to want to adopt such a therapy as a benefit for their members? And then a few comments about the agenda for economic analysis of psychedelics going forward. So why economic analyses? I think you're all aware that there are a range of Schedule I psychedelics that we hope will soon be part of legal effective therapies. To date, economic analyses have lagged behind the clinical research. This is completely appropriate. The focus should be on effectiveness and safety. And you could say, why would you devote resources to economic analysis for interventions where their safety and effectiveness have not yet been established? So that has made sense. I would say it no longer makes sense. There's a sufficient body of clinical research, and you all know this, that suggests potential benefits, that it now makes sense to move forward with the economic analyses so that we can shorten the time that's needed before effective therapies are adopted by payers. Effectiveness is not the same as economic value. So what we want to understand is the psychedelic therapies meaningfully different from feasible standard of care alternatives? And more to the point, is the extra benefit worth the extra cost, which is another way of asking, are they cost effective? So I would say that these analyses are critical for healthcare payers, for private investors, policy actors, advocates, educators, and that all four of these stakeholder groups need rigorous, transparent economic appraisal if access is ultimately going to be available for people who can benefit from these emerging therapies. So now let's take the case of MDMA-assisted therapy for severe chronic PTSD. Is it cost effective? So this is work that we've done. And I want to say, so everything I'm about to present to you is based on a cost of the MDMA itself, which was the best available cost estimate that MAPS gave me at the time. They're now considering a wider range of prices. So the results I'm presenting are the published results based on a relatively low cost of the MDMA itself. Later in this presentation, we'll spend some time looking at the implications of higher prices for MDMA on cost effectiveness, net savings, and so forth. So just bear that in mind as we go forward here. So, but before we get into some of the details of the model and the analysis, I want to clarify one other thing that might be useful if you're not used to thinking about cost effectiveness. Sometimes people conflate cost savings and cost effectiveness. They are distinct. So if something is cost saving, it means that for the relevant payer, over time, they end up with net savings. So whatever initial cost is incurred, the savings in healthcare costs over time result in savings. For something to be cost effective is a lower bar. It just means that it's good value for the money compared to other potential uses of that same money. So if it's cost saving, it's cost effective, but not everything that's cost effective is cost saving. Okay, so with that as background, the answer to the question I posed, is MDMA-assisted therapy for PTSD cost effective? The answer is yes. So the intervention effectiveness as estimated in the pooled results of MAPS's 6 phase 2 trials and the 1 completed phase 3 trial suggests that it is cost effective and thus, cost saving and thus highly cost effective. So third-party payers are likely to save money if they make MDMA-assisted therapy a benefit for their members who are suffering from PTSD. These conclusions are kind of bulletproof. Our model, like all models, has many uncertainties, both sort of underlying assumptions and then estimates for various parameter values. And I want to say, kind of, you can take issue with any individual or even set of variables and assumptions, and it won't make a qualitative difference to our result, which is that this intervention is likely to be highly cost-effective, if not cost-saving. So major features of the model, we built a so-called Markov disease state model that partitions people with PTSD into one of 5 PTSD severity categories. And over time, patients progress to more severe states of PTSD, or they stay in the same state, and the model keeps track of the healthcare costs associated with those disease states and the health status, that is the utility, like their health-related well-being. We assumed that there was no further benefit after the trial. In other words, at the trial endpoint, wherever people were, we did not assume that people got better. Another feature of the model is when people go from severe PTSD, where they have substantial healthcare costs, to remission, where people who don't have PTSD have normal healthcare costs. It's unrealistic to assume that the excess healthcare costs associated with PTSD immediately goes to the lower level associated with remission or no PTSD. It's got to, it's like if people are suffering from for example, PTSD related diabetes, they're not going to go to a non-diabetic condition immediately, and so on with other morbidities. So we assumed a 5-year uniform reduction in healthcare costs as people move to less severe states of PTSD. Yeah, I think those are the important points here. So here's sort of a graphic illustration. I draw your attention to the lower half of this diagram. Here are the 5 health states I mentioned: asymptomatic PTSD, and then increasingly more severe up to extreme PTSD. And at each cycle of the model, or cycle is 1 year, people either stay in the same state of PTSD, or they can progress to a more severe state of PTSD. And at any given time, they can also die. So the model, of course, keeps track of deaths as it progresses. So here's a graphic illustration of the benefits of the intervention. The figure on the left is the control group. So the left-hand side of this graph shows the distribution by disease state in the control group. So you'll see that there's only 2 disease states, either extreme or severe PTSD. And we run it for a lifetime. In this case, we ran the model over 60 years. And as you can see, over time, as you would expect, more and more people entered the death state. And this represents the overall morbidity burden of the disease. By contrast, the figure on the right represents the more favorable distribution of people who received MDMA-assisted therapy. So about 60% were either asymptomatic or were suffering from mild PTSD after the therapy. And so this much more favorable distribution by disease state over time represents the benefit of the model. Another way you can kind of get a visual sense of this is the relatively smaller gray area in the graph on the right compared with the left. That shows the reduced mortality burden for those who received MDMA-assisted therapy. So now let's look at, so that was a sort of graphic representation. Now let's look at some numbers and start with the financial implications. If you assume that the benefits of the MDMA therapy stop abruptly at 3.8 years, the payer would break even. That is to say, at that point, the savings that they accrue exactly, or the discounted savings over that 3.8 years exactly balances the cost of the therapy. But the therapy would have delivered about 900 quality adjusted life years. So that's at 3.8 years. If you assume that benefits last 10 years, this is for 1,000 patients. If you assume the benefits last 10 years, you have savings of about $47 million. I think the other thing I want to draw your attention to here is the bottom of the table, the cost effectiveness results. At 3.8, 10 years, or 30 years, the MDMA-assisted therapy is dominant. So that's jargon in my trade for it both saves money and delivers superior health benefits. So you don't calculate a cost effectiveness ratio, it's dominant. Okay. And at 1 year, so if you assume that the benefits of the therapy ended at exactly 365 days after people completed the therapy, the MDMA-assisted therapy would have a cost effectiveness ratio of about $47,000 per quality adjusted life year. So you might ask, well, is that good or bad? And the answer is it's very good. In the United States, kind of a rule of thumb is sort of $100,000 to $150,000 per quality adjusted life year is considered acceptable. So again, what we're saying here is that even if you thought benefits ended after 1 year, and parenthetically, I'll remark that there's good evidence, well, there's limited strong evidence that benefits actually increase over something like 3.5 years. So it's certainly conservative based on what we know now to think that benefits might last for 1 year. And as I mentioned earlier, these findings are robust. So if you assume that there were no savings in medical care costs, you'd still have over 30 years an incremental cost effectiveness ratio, that's what this ICER is, of about $2,400 per quality, which is great. If you assume that the MDMA patients got worse over time, that their disease progressed over time, but the control group didn't progress, you'd still have net savings of about $70 million. And if you assume that the cost of the therapy is 5 times higher than the baseline cost we used in the model, you'd still have savings of about $87 million. So what does this mean? It means that from a payer's perspective, it looks as if this intervention could be cost saving for patients like the patients seen in the MAPS trials. From a societal perspective, it's even better because everything I just presented are costs and benefits from a payer's point of view. We don't take into account broader societal factors such as productivity effects, potentially less involvement with the criminal justice system, and other benefits that accrue to society more broadly that are not just confined to healthcare payers. So I would say that these results help make the case that access to MDMA-assisted therapy makes sense in human and economic terms. So, so that was an example of a cost-effectiveness analysis. And the agenda for economic research is not confined to cost-effectiveness analysis, although I consider cost-effectiveness a central part of our endeavor. But so I've listed 6 kinds of economic evaluations that could be pertinent here. I'm not going to go into detail on all of these. There's a lot of words on this slide, but let me just talk about a couple of them. The first row concerns cost, which is really foundational. We need to know what the cost of the intervention is, and the net cost, which is, again, the cost of the intervention adjusted for changes in medical care costs resulting from the intervention. Cost effectiveness analysis, you've got a sense of it now. Cost benefit is really another species of looking at value for money, and has some situations has advantages over cost effectiveness analysis. One that I'm interested in, we published one paper on this, and I really want to do more because I think it's important, particularly as we move to appropriate advocacy, is understanding, let me back up. Cost effectiveness doesn't really have a scale. Something could be cost effective and only benefit one person. So that's great. That's a good thing to do with money. That person benefits, but doesn't have an impact on the health of the public more broadly. So in these scale-up models that we're working on, we want to answer the question, what happens if 20% of the people in the United States who could benefit from MDMA-assisted therapy for PTSD had access? What if it was 30%? What if we reached 30% in 5 years as opposed to 10 years? So how many lives saved? How many qualities generated? What would be the savings of the healthcare system? And my fantasy is somebody is testifying before Congress. And the question is, should money be allocated to a psychedelic therapy? And that person should have available credible projections on what sort of the aggregate effects are on on healthcare spending, on the economy more broadly, on again on mortality and health benefits. So scale, and then price analysis. What's an appropriate price for these interventions? They need to be high enough to attract investment and the risk that's involved in developing the therapies, but low enough to ensure access and receptivity on the part of payers. It's complex. And then finally, methods development. So I'll just say there are a few areas, but the one that kind of interests me the most is we health economists are stuck in a paradigm that's limiting. So the way we think about health benefit is on a scale that goes from, or health utility or health state, is on a scale that goes from 0, which is death, to 1.0, which is the absence of a disease or disorder. But we don't account for positive health states. And as you know, people exposed to psychedelics, both in clinical and in naturalistic settings, report increased access sometimes to states that go beyond the mere absence of disease. And so we're working on integrating the measurements of these positive health states. And there's a lot of work has been done on, again, measuring these states and so on. But what hasn't been done is figuring out how to integrate them into conventional economic analyses. I believe cost effectiveness of psychedelic therapies may be underestimating the benefits because we top out at 1.0. That's our ceiling. And any benefit beyond that, I think you get the point. Okay, so I'll stop there. So I like to say ours goes to 11. We want to figure out how to make this go to 11 and include positive health states. Okay, so now I want to give you the example I mentioned earlier, and look at the effect of drug price on 4 benchmarks that payers and society would care about. So those 4 benchmarks are net cost, and you now know what I mean when I say net cost, cost effectiveness, which is bang for the buck, break-even time, which you also, I referenced that earlier. It's like when do costs and savings even out and net out to 0. And then the last one is percent of operating revenue of a payer organization. I'm going to use the example of Kaiser just to illustrate what I'm talking about. So this graph shows 4 different prices of MDMA itself. We're not talking about the whole thing. We're talking about the medicine itself, ranging from $1 per milligram up to $20 per milligram. The other thing we're varying here is the analytic horizon, which we're varying from 1 year up to 10 years. So the first thing to notice is the longer. So anything above 0 it's resulting in net costs. Anything below 0, all of this here is savings. So the first thing to notice is that the analytic horizon has a big effect on the estimation of net costs or net savings. The longer the horizon, the greater the savings, because you've got more time to accrue benefit. It's basically what's happening. And then the price of the drug also has an effect, but it's relatively modest. So at 1 year, if you took the high cost of the drug, $20 per milligram, for 1,000 patients, you would have net costs of about $19 million. If you use on the other side, the low cost of MDMA, $1 per milligram, savings are reduced to 11.5 million. And similarly, on the 10-year projection, you've got savings of about $47 million on the low price of the MDMA, $1 a milligram, and somewhat lower savings of $40 million. So I don't know about you, but I was a little bit surprised when I saw how insensitive these results are to the price of the drug. And I'll make that clear. So why that is. Yeah, so the net costs are relatively insensitive to the cost of the MDMA itself. And this is an important point. We don't know what the cost of MDMA is going to be. So MAPS is working hard on making that determination. I don't think a final determination will be made until the FDA approves of it, and it'll depend on labeling, and there's lots of factors. I have no particular insight into all of the things that they're thinking about. All I know is they're considering a very wide range, and the actual price could well exceed $20 a milligram. So at the low end, here's what the cost composition of MDMA-assisted therapy is. And you can see that most of it is personnel. All of this is personnel, so it's about 85%. Pharmacy, that's another way of saying the drug cost, is only 3.3%. At $20 a milligram, pharmacy is now 40%, and everything else is proportionately reduced. So clearly, it has an effect on the composition of the composition of the cost of the therapy, but not that much on the overall price. So let me go back. At $1 a milligram, we're at about $11,400 per patient who completes the therapy. And at $20 a milligram, it goes up to $18,500. That's a substantial difference, but remember, we increased the cost of the drug by 20-fold. So I've been speaking about how cost and net cost varies by the price of the drug, but what about cost effectiveness? So looking at the 1 year and 3 year analytic horizon scenarios, at $1 per milligram, if you assume benefits cease after 1 year, this is that roughly $47,000 per quality figure I gave you earlier. Over 3 years, it drops substantially, and at $20 per milligram, we're at about $75,000 per quality, still quite acceptable if you assume only 1 year of benefit. If you assume 3 years of benefit, we have a much more favorable cost effectiveness ratio of about $17,000 per quality gain. Now, you might be asking, how come we don't have the longer, the 10 and 20 year projection? Oh, so first of all, just to remind you, between $100,000 and $150,000 per quality gain is acceptable. And then you might be asking, why results for only 1 and 3 years? What about the longer analytic horizons? And you'll recall that once you get past 3 years, you're in saving territory, so you can't actually solve for a cost effectiveness ratio. That's why this graph only has 1 year and 3 years. Okay, break even varies from 3.7 years for $1 per milligram price of MDMA up to 4.7 for 20 years. So again, not particularly sensitive to the price of the drug. So now I want to introduce some caveats. Everything I just told you pertains to the kinds of patients who were seen in the MAPS trials. And these patients had severe or extreme PTSD. In the case of the phase 2 trials, had on average 18 years of PTSD, and in the case of the phase 3 trials, 14 years of PTSD. So very chronic, severe or extreme PTSD, and treatment resistant. They failed, almost all of them failed 2 or more therapies. So what happens if MDMA-assisted therapy is extended to patients who are less severely affected by the disorder, and including what if it is made a first-line therapy. It is clear that the cost effectiveness would become far less favorable, and there's at least 4 reasons for that. One is, if you're treating people who are less severely affected, the healthcare spending for those in those less severe states is less. So there's less money to save if they go into remission or they improve. And similar logic pertains to their health status. There's simply less benefit to be obtained for people who are less severely affected by the disease. The other thing is that there's a fair amount of spontaneous remission within the first year or so of being affected by PTSD. So you could say that treating patients in that group is, in quotes, wasted. They would have gotten better anyway, and you spent, substantial money on a treatment that would not have made a difference for that subset of patients. And finally, standard therapies work for many patients with PTSD. So if you put all that together, it's unlikely that you would see, let me put it differently. The likelihood of having the kind of extremely favorable economic results that I mentioned earlier is extremely small. I mean, the only way this could happen is if the therapy was extraordinarily effective for people with milder PTSD. So anyway, so it's just something to think about as we talk about expanding access to a broader group of patients with PTSD. So then the final benchmark that payers might look at is how it affects their budget. And I just did a little exercise where I used Kaiser Permanente as an example. They have operating revenues of about $93 billion. Let's see what I want to point out to you here. Yeah, and so based on what we know about the prevalence of PTSD in the US population as a whole, that would mean about 170,000 people might be eligible for treatment in Kaiser nationwide. If the cost of MDMA was $5 a milligram, the total cost for Kaiser would be about $2.2 billion. Now, that's not all going to occur in 1 year. So if you spread that out over 5 years, the break-even point is about 4.0. And as a percent of operating revenue, this is about 0.5%. At $20 per milligram, I'll just go to the bottom line here, as a percent of operating revenue, making this therapy available would be about 0.7%. So that may not sound like a lot, but as kind of a rule of thumb, a budget increase for a single new drug of $50 million for a public payer or $100 million for a large private payer might be a red flag. And as you can see here, we're talking about increases of much more than those kind of red flag rules of thumb might suggest. So this could be of concern in thinking about how payers are going to respond at various price points. So stepping back from that analysis, I just want to tell you a little bit about what our group is doing at UC Berkeley. We are working with Matthew Johnson at Johns Hopkins on the cost effectiveness of psilocybin for smoking cessation. You're probably aware he's gotten very, very promising sort of interim results on psilocybin for tobacco addiction. We're building a model for looking at the cost and cost effectiveness of psilocybin for major depression in partnership with USONA. psilocybin MDMA for PTSD in Brazil with Eduardo Schenberg. I've got a group working on understanding the public health implications of use of psychedelics in non-clinical settings, and we're focusing on non-classic psychedelics, so MDMA, ibogaine, and other sort of non-classic serotonergic psychedelics. We have a proposal under review at the Department of Defense to look at MDMA for PTSD for active duty military. And we're also building a model for looking at the economics of ibogaine assisted therapy for opioid use disorder. So what's the broader agenda for economic evaluation of psychedelic therapies going forward? I developed an equation to answer this question, and I want to share it with you. If you take the number of relevant molecules and combination of molecules, and you multiply that by the target psychiatric indications for which they might be effective, and you multiply that by patient subpopulations, treatment resistant, non-treatment resistant, milder, more mildly affected, more severely affected, and you multiply that by variations in treatment regimens, 2 active drug sessions, 3 active drug sessions, group sessions, individual sessions, mix and match those any which way you want, multiply that by the number of countries, you get something like an infinite amount of work to do. So there is a huge area of research here for my group, and we can't do it. So I am welcoming partners and others to jump into this space, and let's get this done. Okay, thank you.
Thank you, Dr. Marseille.
Should I continue? I'm sorry to interrupt you. Should I continue sharing, or should I sharing my screen, or stop sharing?
This is a good
People may have questions from the.
Yeah. If I need to show a slide, I'll go back.
Yeah.
Yeah,
I did want to give Peter Hendricks a chance because he's about to get on a flight pretty soon, but he sent me a message saying he had a question he wanted to ask. So Peter, why don't you kick it off? If you are with us.
Wait, ask them to unmute. Hopefully that'll do the trick.
Okay. There we go.
All right, can you guys hear me?
Yes, loud and clear.
Dan, let me know if you can hear me.
Yep, you're audible.
Hang on. Let me try one more time. Anyone there?
Yep.
Yes.
Yes, we can. Hear you.
Okay, good. Sorry about that. Elliot, thank you so much. I'm in an airport right now. I'm returning from Cleveland Clinic where I was talking a bit about psilocybin, but I really wanted to hear and see this talk. So I've been listening and watching from the Cleveland airport. So forgive me for the background noise, and forgive me also for not sharing the beautiful background that is the Cleveland airport here. But I really, really enjoyed this talk, and these questions are really critical. And I'm so glad that you've been doing these analyses. And in fact, I know I just edited a really nice piece that you wrote for Frontiers in Psychiatry. I think we've finished that process, and that will be hopefully out there for people to read soon. But I really admire your work, and this is so fascinating to see and to try to understand. I'm a clinical psychologist. Dan is a clinical psychologist in training, and Itamar is a psychiatrist. These might not always be the sort of issues that are immediately digestible to us, or at least to me. I'll speak for myself, but I just think it's so important. So thank you. The question I had, and one that sort of keeps me up at night, is, and perhaps you've answered this, but I'll ask it directly. It seems like you could make an argument around cost effectiveness to managed care, but ultimately they're going to be mostly interested in how much they're going to have to pay, with maybe not as much of a concern about effectiveness or longer term gains especially if they say, well, most of our customers, and that's, I guess, how they'd refer to them, will no longer be customers within a year. So if we pay for this really expensive treatment that is going to, let's say in the case of smoking cessation, or whatever it might be, prevent expensive interventions in the future, or whatever it might be, one very jaded response on their part might be, however, that individual won't even be our customer then. So, why does it matter?
Yeah.
This isn't really what I'm thinking. I'm just curious what you'd say to that.
No. It's really a pertinent question. So, Peter, what you're referring to is called in the trade churn, which is people leaving one health plan for another. And the churn rates are very high. So people, these numbers aren't exactly right because I don't recall it, but they're pretty close. Until recently, kind of the best estimates for churn rates was that people left on an average, they stayed in a program for an average of 4 years. There was a nice paper that came out a few months ago that revisited that and took into account of people going back into a program. And so if you kind of net that out, it's considerably longer. It's about an average of 5 or 6 years, like that. But the issue remains the same. It's the one you said. Why should we bear the upfront cost? Patients, we pay for these patients, and then they migrate to another plan, and some other plan gets the benefit of their improved health. And that's why these break-even times are really important. And why, while cost effectiveness is not very sensitive to the price of the drug, at the margin, it could make a difference if the break-even time was 3 years or 4 years or 5 years. So I'm basically agreeing that this is an important point. However, it implies that payers would only accept these interventions if they saved money. And payers pay for all kinds of things that don't save money. They're just a good use of money. Some of them aren't even a good use of money, but in other words, the criterion isn't necessarily that it has to save money. It's nice if it does. It makes it much more compelling. And I think, because these are formally illegal and stigmatized, well, still illegal, but the idea is they'll become. Anyway, the point is, since these are stigmatized, they may need extra persuasion to accept these, kind of controversial therapies. Sorry, it's a rambling answer, but I've heard people speak about insurance companies. I say, how important is cost effectiveness? And I hear everything from it's really important, it's absolutely critical we look at it, to an answer that I don't fully believe, which is we don't care about cost effectiveness. We'll do whatever it takes to provide good services to our members. And so I
find that hard to believe, but it would be nice if that were true.
Yeah, well, I think where the truth lies, I think, is that of course they look at cost effectiveness, but if something is good value for the money, it doesn't necessarily have to save money.
Oh, well, thank you. I'm not sure if you had finished answering that question, but thank you so much. That's a satisfying answer, and I again really appreciate you coming to speak. And from my perspective, these questions are some of the most crucial questions that could possibly be asked. And it's always nice to run a trial and show an effect of intervention, but these real world questions are really crucial. And I would imagine there are a number of interventions that might be in many ways very effective, but could never quite make it to market because the cost is just so prohibitive, or that cost effectiveness ratio is just not going to work out. So thank you so much for this and for what you're doing. And I'm going to go ahead and mute myself and let somebody ask a question, but thank you again.
Thank you for your encouraging words, Peter. I appreciate it.
Thanks, Peter. We got a question here from Alex Klein. Alex, go ahead.
Thank you so much for the talk. Very, very interesting. Very much appreciated. And I actually want to hone in on one of the things that you kind of mentioned briefly uh, about the about health economists having that 0 to 1 scale, and the idea of positive health states not really being accounted for in that kind of analysis. And the question is, do you have any ideas on what kinds of measures should or would be included in such a positive health state?
Yeah, yeah. So I'm trying to remember the names of the particular measures that are our best candidates now.
Hmm.
Do you know who Dr. Keltner is at UC Berkeley? If you're particularly interested in this question of, he's Dr. Dacher Keltner. You can look him up. He's at the Berkeley Center for Psychedelic and Consciousness, whatever that their center is called. And he's one of the leading researchers on the measurement and determinants of happiness. And so we have a set, I can send these to you offline, a set of candidates. I use like the actual names of them. One is the awe scale. And it's a whole big burgeoning area of research. Yeah, so feel free to contact me, later. I'll send you some material.
Awesome. Thanks so much.
Yeah.
I actually had a question, which is, so my understanding is your projections here were sort of based on the MAPS data that is present so far that's been available for these kinds of analyses. Now, my understanding is once this really hits the market and kind of enters the wild, there's going to be a lot more sort of variability in outcomes, in sort of like therapeutic protocols, that sort of thing. I'm wondering if you have anything to say sort of about how you expect these kinds of cost effectiveness estimates will change over time, like as this becomes kind of more mainstreamed.
Yeah, I do have thoughts. They'll get worse. I mean, because the efficacy found in well-resourced clinical trials. Can you hear me? I'm getting a message that my connection is unstable and you're frozen.
A little choppy, but you're audible.
Okay, all right. Anyway, there's a well-documented difference between efficacy found in clinical trials. I'm not talking about psychedelic, I'm just talking about in general, and real-world effectiveness. It's easy to understand that, why that would be true. So I think we need to assume that will occur in the psychedelic arena, and the idea is, to control that as much as possible, to put in place sound screening methods to make sure that the post therapy sessions are good, that there's plenty of integration. I'm also, here's a concern that I haven't heard addressed enough, which is it's likely that there will be a small portion of people who, however well screened and however good the wraparound therapy is, are going to be destabilized by the psychedelic experience. And I think we need to start thinking about, I think there's an ethical obligation to provide them the support that they're going to need. And as a practical matter, we're sort of have a moment in the sun right now. The public opinion and media has been very favorable. It wouldn't take very many stories about somebody really, having great difficulties after use of psychedelics in a clinical setting, right, to turn that climate of opinion. So I think it's something that we should start thinking about. But just again, to return to your original question, we can assume that the measured benefits will decrease from what we've seen in the trials. And I can't hazard a guess as to how much they will decrease. It depends, like you said, on how well it's done and the protocols that are set up and the training of the therapists and all of those factors.
I agree with everything you said. And I also definitely want to highlight that I think sometimes those kinds of cases where people actually get harmed by a kind of therapy like this kind of get washed out of the equation, because it's just like, well, look at all the people who are tremendously benefiting from it. A lot of those stories, and there are genuine risks. And my understanding is that, as this becomes more prevalent, those risks are also going to increase. And in part because I think there's an incentive to kind of find ways of cutting corners here and cutting costs. And by doing that, you're kind of taking away, probably therapeutic support is going to be one of the things to go, because you can't really, the drug is kind of going to be at a fixed cost at a certain point, but they can be like, well, do you really need this many sessions with a therapist? Maybe we can kind of dial that back. And then that ends up becoming, potentially riskier and potentially more harms. So thank you for bringing that up. I think that's a really important point. Anybody else want to jump in here? Any questions?
I just wanted to add to your point, Dan, I think too, the range of, various disorders and things like that, these treatments are going to, there'll be such a diversity of applied treatments. I just think there's so much to consider from that avenue as well, in terms of training, and it's such an early stage. I'm very curious what a kind of standardized integration treatment would look like, or if that's something that's already becoming kind of streamlined in the industry. But
if I can actually, I think that's a really good question. I don't know if I have the same question as you, Kevin. Maybe I do, and maybe you can answer, Dr. Marseille, which is, has consideration been given to the scale-up cost? I think you actually did, in terms of some infrastructure exists to implement this on a clinical trials basis, but in order to actually scale this up to a national level, what consideration has been given to those costs and those difficulties?
Yeah, no, I think it's really time to start thinking about that. So it's the infrastructure costs, which may not be that great. It may be that the existing physical facilities are sufficient, but we know there are big supply constraints, that there are not enough trained therapists. We don't know. We don't know how willing therapists are to provide this therapy. It's grueling, to eight hours, and not everybody's cut out for it. Even people who go through the training, they may only want to do it once every couple of months. So we don't know what the capacity is per trained therapist to actually, sort of the throughput of patients, of the number of clients they're willing to take on per unit of time. That's going to depend, because I'm an economist, I have to think about money, is going to depend to an important degree on their compensation. And here's another problem. I mean, therapists don't like to take insurance. A very large portion of therapists don't take insurance. I was talking to one in New York at the Horizons Conference. She said, yeah, you take insurance and they own you. The insurance companies constantly asking you to justify what you're doing and reporting, and and the delays in getting paid, and the reimbursement levels are also low. And I think this is something we're going to have to address, is the incentives for therapists to take this on, and includes their financial compensation. So again, I'm not answering your question, or I'm sort of talking around your question. Yeah, right. But so major questions about this on the supply side as we scale up. So there's sort of areas of healthcare finance that we need to address. Yeah.
It seems like, in part for that reason, I've heard a few people say that they think the group therapy model is going to be one of the most cost effective, because of just the time it takes. But I think there are other benefits as well. I mean, people get more social support, for example, and I think that's huge for treatment.
Dan, thank you. Thank you for bringing that up because, I'm sort of like talking about, yes, effectiveness is likely to get worse and so on. But group therapy will definitely reduce costs in a way that's completely intuitive and easy to understand. My hunch, I'm not a clinician, but my hunch is to agree with you. My guess is that people will get more benefit in the group sessions, like measurable benefits. Need to find out. That's a really critical question at this point. And so that could be sort of a countervailing vector, against this deterioration in benefit that would otherwise occur as people. Yeah. So where that nets out, I don't know, but I'm glad you mentioned group therapy. It's MAPS had this very, clinician intensive, one client, two therapist model for reasons that make total sense at the time. I mean, it was like they wanted to signal we're providing all the guardrails, all the safety, all the care, and that was appropriate. I'm certainly not second guessing that, but it's now time to explore other models. Yeah.
Anyone else want to jump in? We got time for maybe one more.
There have been some really good questions. I guess I have one very simple and maybe kind of boring question, so I feel bad to end on it.
I'm an economist. I traffic in boring. That's what I do.
What can you say about the incremental cost effectiveness per session? Or is there an optimally cost effective number of doses that someone should receive?
Yeah, right. So we don't know. It's in that infinite number of analyses we need to do. Our group, we answered the question. So in the MAPS phase 2 trials, it was 2 active MDMA sessions. And in the phase 3 trial, it was 3. And we looked to see whether the incremental cost of that 3rd session was justified by the incremental benefit, i.e. was that 3rd session cost effective? And the answer is yes. So yeah, so 3 is better than 2. Probably it's safe to say that 2 is better than 1, although that hasn't been, yeah. And so then, well, maybe 4 is the way to go. Or you do 3, and then people who haven't responded to the 3 sufficiently, they're still whatever, severe or extreme, they get a 4th, maybe. So we would just be focused on that smaller subgroup. But these are the kind we just don't know. These are the kinds of questions that we need to start answering.
Thank you, Dr. Marseille. I think we'll wrap it up here. It has been a true pleasure. Such a smart and interesting lecture. And we also appreciate all of our audience that asked such good questions. So if people want to reach out to you or get more information, where should they go?
They can go to, really, they should just email me, or they can go to the Gypsy website, but it's really, there's not much on it, really. If you want more information, just contact me.
Okay.
All right. Thank you so much, Dr. Marseille. Thank
It's
you,
been my
everyone.
pleasure.
That is a wrap for PSF for this semester. Just stay tuned for new stuff in the new year.
All right.
Everyone.
Bye-bye, everybody.
Bye, guys. Thank you so much.